brilliant idea. Hussam and Tavreed have created this platform to help and to educate people. Um, they have really interesting webinars like in sleep and affective disorders that I personally think are very useful to me. And I've been practicing for so many years, so it will be really helpful to most of us. Thank you for inviting me. I'm really happy to be here. I'm even more happy to have a lot of colleagues from Egypt to be around and to share my knowledge, my experience in this particular area, which is a relatively new area to the practice. One good thing about not having a big crowd is we can have this as interactive as possible, and people can ask questions and I'll be more than happy to answer the questions that can be answered. So the big question for today is neuromodulation the future of psychiatry? Are we seeing a change in how we practice through the introduction of this new thing, neuromodulation? I'll give you a little overview of what to expect today. Today, we're going to talk in general about neuromodulation, but more specifically about TMS, which is by far the most used neuromodulation technique after ECT. And I think if you've been practicing long enough, so 6 months or more, in any part of the world, you would have known ECT already. But TMS, in the new wave of neuromodulation, TMS is by far the most practiced technique of neuromodulation. And hence, we're going to focus a little bit on it. I'm going to talk about the mechanism of action of TMS, specifically in depression, because it's the most commonly used. It's most commonly used in depression more than any other indication. We'll talk about how effective, and we'll talk about side effects. And the interesting part is the emerging indications, the new things that we're going to be able to use neuromodulation in general and TMS in particular, other conditions, other indications. And I'll give you some examples of other types of neuromodulation towards the end of this talk. So, what is neuromodulation? You can read the definition, but in simple terms, neuromodulation is the process of changing the behavior of neurons, and by virtue of changing the behavior of neurons, we change the behavior of neural circuits in the brain. We make the neurons work in a different way, whether upregulating or downregulating that activity at cellular level through different techniques. And by changing the behavior of those cells, and by virtue changing the behavior of the circuits of the brain, we're able to make a change, a therapeutic change to different parts of the nervous system. It can be the central nervous system, which we work with a lot, the peripheral nervous system, we are not that concerned with, and also the autonomic nervous system, which is quite important for us as psychiatrists as well. How can we do neuromodulation? It can be done through electrical or magnetic or chemical means. By definition of neuromodulation, it is non-destructive. We are not using a knife to cut a circuit to make it behave differently, and it's reversible. Once we remove the factor, the TMS or the other intervention, you go back to normality or baseline, and it's adjustable. We can fine-tune it. Examples of neuromodulation. So, as I said, by far the most commonly used and reputable is RTMS, repetitive transcranial stimulation. And I'll talk a lot about this. But you will find other tools that are becoming also quite popular, like tDCS, transcranial direct current stimulation. If you're on Facebook, you can easily spot. You probably can hear the children in the background, guys. So I told you about this. If you're on Facebook, you will find all these sets being sold for the flow sets and similar Plato sets for tDCS. They are useful, actually. And if you start after today's session searching these things, you will be bombarded with a lot of them. The other type of electric stimulation to the brain is transcranial alternating current. Instead of direct current, you have alternating current. Deep brain stimulation, we'll touch on this. Vagus nerve stimulation will touch on this towards the end of this session. Trigeminal nerve stimulation, it's actually quite interesting. No one was talking about it for years. It came as fashionable 20 odd years ago and went out of fashion because its effectiveness is not great, maybe, but it's quite effective in a certain group of people with ADHD. And as ADHD is researching, TNS is going to be a thing. I'm not going to talk about it today, but I'll probably touch on it in the webinar, in the ADHD webinar. The next one is focused ultrasound neuromodulation. Very interesting. You use ultrasound, the one that we use in nephrology, but without the same intensity. We're not breaking anything to change the cell behavior, the brain behavior. And this one in particular is very promising in the field of dementia and Alzheimer's disease. Obviously, chemical neuromodulation, ketamine and psilocybin, and obviously DMT, if you're following all the discussions about ayahuasca, dimethyltryptamine, obviously, they are becoming really, really popular as possible routes for rapid acting, fast acting antidepressants. We're not going to touch on those ones today, but they are worth another discussion, probably with our resident expert in the matter. I'll leave it to Hassan to advertise this. Okay, so these are the main neuromodulation tools that we have around. Some of them are very effective, some of them are not as effective, but they are really exciting to use. Let's just have a little bit of history about TMS, Transcranial Magnetic Stimulation. If we have to look back, we need to spot the point in the 1700s, in the 18th century, when, as human beings, we discovered that the brain and the nervous system works with electricity by Galvani and Volta. They were the ones who said, by the way, we're electric animals. Our brain, our nervous system works through electric voltage. Then, over 100 years later, almost 200 years later, Chialetti and Binney introduced ECT. And ECT very quickly became a big thing. And we started using ECT for everything, and treatment for depression, bipolar, schizophrenia, even without mental illness, it was used. But ECT does not come without its own controversies, difficulties, especially cognitive problems, especially all the bad media in the American cinema in the 1950s and 60s, which made people really go off ECTs, and it became almost like a very stigmatized treatment that people try to avoid. tens of years later, a guy called Anthony Baker here in the UK, who works in Sheffield, started working on a TMS machine. So this guy managed in 1985, he's still alive, he still works in the field, this managed to make a demonstration of how using transcranial magnetic stimulation can affect the nervous system. He was initially working on rehabilitation of the spinal cord, but at some point decided, okay, if it works on the spinal cord, it might work a little bit higher. Maybe it works on the brain. And with him was a guy whose name is Mark Anthony. He is the father of modern TMS, who is still practicing in the US. He was just doing a residency in the UK at the time, got the idea, went to the US, started working with different companies, developed the machine, and in 1995, published the first big trial on using TMS in the field of psychiatry. And as they say, the rest is history. By 2008, there has been enough research in this area for the FDA to approve it for the treatment of depression. It took NICE in the UK, the people who issue guidelines, 7 or 8 years after that to just wake up and understand that this treatment, which was originally developed in the UK, is something that we can use. By 2015, they approved it for the treatment of depression. The history doesn't stop there. In 2013, it was approved for migraine with aura. For migraine, it's actually one of the very, very best treatments that people can have. It's phenomenally effective. 2017, it got a license in the US for OCD, 2020, smoking cessation. As we go along, I will explain, it will be clear why it have those effects in completely different areas. What brings smoking cessation to depression, to OCD, to migraine, as in, if I remember it correctly, اللي جاب القلعة جنب البحر حسب الفيلم الليمبي. So there are really different things that come together. In 2021, anxiety was comorbid depression, and this year in the US, they approved it for the treatment of children, adolescents with depression, so 14 and over. We, in our center, we are doing a big study on adolescent psychiatry ourselves and in teenage depression from the age of 14, and we will be recruiting from January this year. Okay. Let's start with TMS, the main treatment that we are going to focus on today. I put the definition, and it's wordy, it is full of, it's not easy, but what we're going to do in the next 10 slides or so, try to decipher, try to dissect it a little bit together. So TMS is a focused, non-invasive stimulation of the cortical brain areas using rapidly switching extracranial magnetic field, inducing depolarization current and leading to direct activation of and modulation of brain activity. So it's focused. So as opposed to ECT, which is not focused at all. It's electricity going everywhere. So this one is really different because it is focused on an area. Non-invasive, no anesthesia, nothing going inside the brain, except you're just touching the head. You're stimulating the cortical areas. So remember that, to remember that the stimulation is just going up to the level of the cortex. It doesn't go any deeper, which has been a point of contention for many years, because a lot of people said, you can only stimulate up to 6 or 7 centimeters. How on earth do you think you're stimulating the brain? okay, using rapidly switching extracranial magnetic fields. That will be explained in the next slide. So the magnetism element of it to induce depolarization, leading to the activation and modulation. Okay, so we're talking about energy, electromagnetic, focused on the brain in a non-invasive way that is going to change the behavior of the brain through stimulating the cortex. To understand this, I have to tell you the story from the beginning. Like the guy who does the thing on the Egyptian TV. أحكي لك القصة من الأول. Okay, so the story starts from this guy Faraday, again, another English guy who one day was working in a flat in London and discovered that if you push electricity through a coil, the coil changes into a magnet and it creates an electromagnetic field. This electromagnetic field will be perpendicular, coming at 90 degrees to the center of the coil. But the amazing side of it is if this electromagnetic field gets in contact with a conductor, a wire, a metal, it changes back into electricity. Is that clear? Everyday use of this. Where do you use it? A lot of people, do you use this wireless charging of the phone? How do you think that the phone is charging when you put it on a small plate? The small plate is connected to electricity, and the small plate have a coil. And the coil, when it has the alternating current coming to it, it creates an electromagnetic field. When it touches a conductor, which is your phone, it changes back into electricity. And that's how so we're basically in TMS charging your brain. The same way we are charging the phone by giving electricity. Okay?
I have to say, I do like this metaphor about charging the brain.
Yes, it's.
And I never thought of it. I know the Faraday cage, and I thought about the old videos that I watched, not very old, I mean, when I'm learning about electricity and whatnot, and the engines, certain types of motors or engines moving. But when you explained it with the charging, with the phone charger, the wireless phone charger, it made, I have to be honest, it made more sense. And sounded more attractive, definitely than than explaining
Because I know
the
nothing
whole
about
Faraday
engines as
law,
well.
which
So
which is very
that
helpful.
saves my face.
So yes, thank you.
Good. Okay. Back to first year medical school. So the physiology, which all of us loved and cherished, didn't we? So what happens when we give a brain cell, a neuron, a single pulse stimulation? So now we pushed the electricity through the coil, and the coil created a field, and the field got in touch with the brain. So a brain cell got a little bit of electricity through the TMS. What happens then? First thing that happens is you give the brain electricity, you cause depolarization. So you open the voltage-gated sodium channels, the sodium rushes out, and then it creates an action potential, if you remember it. And then after that, the potassium gets gets an efflux, not influx, and from the point of stimulation to the point of repolarization, you get a period where the brain cell becomes dormant, the refractory period, which is quite important for us in TMS because this is what's going to define what we are doing. Are we stimulating or are we inhibiting the brain? So just it's nice to remember that this is what happens. You give a little bit of electricity, you cause depolarization, repolarization, and remember the refractory period. Once this activity has happened, a population of the neurons, the pyramidal neurons, will be activated, and you can measure it by measuring the motor evoked potential, the amount of electricity that was needed to stimulate this part of the motor cortex. And again, that's really important for us because this is how we understand, this is how we measure how much energy, how much electricity is needed to stimulate a brain. It will become a little bit clearer after that. Okay? What happens when we repeatedly stimulate the brain and the brain cells? 5 things happen here. I will focus on 2 of them. We enhance the synaptic efficacy. We make the synapses work more effectively and work in a way that is desirable for the brain state, whether we enhance it to work harder or we suppress it. Through the process of repeat stimulation, getting a lot of activity in the nerve cells, we increase the spine density, and there is a change in the shape of the dendritic ends here. There'll be a lot more ramifications. There will be a change in the neurotransmitter activities, and over weeks and months, there will be a change in the shape and the function of the neural circuits. So the network itself between the parts of the brain will change. I will explain more. I know it's a little bit old talk, things that we have studied a long time ago. Okay? So, if we go back to physiology, there is a principle of something called long-term potentiation and long-term depression. This is probably the most important change that happens in TMS. So TMS, by stimulating, activating the neurons repeatedly, it changes the behavior of the cells in a way that they become more active. And when they become more active, there will be increase of the number of receptors, mainly glutamatic receptors, in the presynaptic and the postsynaptic area. Okay, that means that the postsynaptic receptors are having more monoamine activity through this process of long-term potentiation. But if we're giving an inhibitory tool through TMS, we can also cause long-term depression, suppress the activity, which means reducing the number of AMPA receptors, glutamatic receptors. Okay? Is that clear? Sam, is that clear, or is it too technical?
Let me rephrase. We have a question. Someone raised their hand, so I'll wait.
Marwa?
Marwa, yes.
Go ahead.
In whichever language you would feel free to speak.
Okay, I didn't understand how come we can deliver inhibitory tool through TMS. You mentioned
Very
if
good.
we if we deliver inhibitory, so we got depression, so we reduce the glutamate receptors or something like that.
Okay, right. I'll take you back to this. So that's why I said it's really important to understand. I was just waiting for this one, the refractory period. Okay.
I'm sorry, but the shared screen is not pinned, so I cannot focus on it. Can we pin the shared screen?
Sorry, what do you mean by
I don't know.
share the screen? Can you not see the screen itself?
Yes.
What can you see on the screen?
You?
شايفة إيه على
Oh, okay. Do you want to look into your view? You know, there is a button that says view.
Yes.
Press on the view button and change the view from your direction to make it as standard. You should be able to see the slides.
Yes, I see it, but I see it very small. I cannot focus on what's written on the
Oh,
screen.
okay. I don't think I control that, to be honest, as far as I understand.
Maybe if we pin the screen,
Okay.
the shared screen, it would be larger.
I don't know how to do this.
Give me a second. Let me change theme.
Zoom. I'm not in a mobile. I am laptop. I cannot zoom.
Post video order. Not sure, to be honest.
It's okay. It's okay. I don't want to interrupt the meeting.
No, don't worry. Yani we're a small number, which it's a good advantage to be able to explain this.
I can hide lots of things. I cannot show many things. Let me see. Lock meeting, enable meeting room, hide pictures. Shares. I have to be honest, I am not sure how to pin the screen if there is a thing.
Right. Marwa, look,
Yes.
if you can see this small screen of the action potential.
Yes.
You see this part of the curve that I'm pointing at, this dip in the curve. الحتة اللي نازلة خالص اللي هي refractory period اللي مش هيحصل فيها حاجة مهما عملت. Okay. What happens if you actually stimulate at a rate that would keep the action potential always inhibitory? انك انت it is about the rate. So you stimulate at a low frequency that 1 hertz, for example, that would lead to this action potential to go up once, but then when it's inhibitory, you give another to keep it inhibitory. So you stimulate the nerve every time it's coming from the inhibitory to become inhibitory. Continuous stimulation that wouldn't allow recovery. That's inhibitory stimulation.
Okay.
Or inhibitory firing.
Okay, got it.
Okay. And if I may ask, was there something similar to this kind of used in epilepsy?
Actually, yes.
This might now, as you mentioned the inhibitory bit, now I'm remembering someone mentioning something about some sort of
and they have tried it in epilepsy, inhibitory, and the inhibitory tried in for example, tic disorder.
Okay.
So it's really interesting that if you give inhibitory pulses on the right side, dorsolateral prefrontal cortex, you can actually stop tic disorders.
But one of the side effects would be potentially depression.
No. Right side does not cause depression.
Okay.
Right side stimulation is just inhibitory for this particular area. So you're probably going to do it on the right side for this, and you can also do the right motor area as well for inhibition. So one of the side effects of TMS is having epilepsy, but actually if you're good enough to to target the area related to epilepsy, you can, in certain cases, reduce it. It's not licensed for this use, but that's definitely been
There's
thought
been
about.
research in that sense.
Yes.
Okay, that's helpful. So if I'm going back, I'm sorry for this. If I understand correctly now, if you just go and back. If we think about depression, and we think that one of the theories about depression is that basically there isn't enough neurotransmitters in the synaptics, and this is why we use selective serotonin reuptake inhibitors or MAO inhibitors, that we are blocking the reuptake to allow more receptors in. So this is one theory around depression, the serotonergic receptor theory, or the monoaminergic receptor theory. The other thing is, we know that people, let's say, at least I know, that people, let's say, who had long-term therapy can go through certain neuromodulation where the brain wiring or the brain synapses change to become a bit more healthy. So if you practice a certain skill, if you practice sports and music, or you go to therapy regularly, we know scientific evidence that the brain structure or the brain wiring change in a sense. And basically what you're saying is, with the TMS, with the repetitive wiring,
Stimulation, yes.
with the repetitive, stimulation, we do, number one, we allow more in the synapses. We allow more and more monoaminergic or MAO in the synapses, which treats the depression. And eventually, with long enough time, the synaptic plasticity and the network modulation starts to happen, where the wiring works kind of the right way.
Exactly. Exactly. So in the synaptic space, you have you have more monoamine oxidases, so you have more serotonin in the synaptic space, but also over time, you have more postsynaptic receptors to get it through.
Okay, there is an enhancement in the postsynaptic receptor as well. So there is more sensitivity for these.
Absolutely.
Yeah.
So you're making
the
it work better.
postsynaptic receptor becomes more sensitive, more accepting, more taking of these
Absolutely. So that's by far, yeah, because synaptic plasticity is about learning, isn't it? So the concept of synaptic plasticity is learning. Is you learn in person by doing an effort. You make the neurons learn by repetitive stimulation.
Okay.
So you're doing the same effect, but by repeatedly giving them signals. So signaling. So they learn, oh, yes, I need to be, this needs to go this way. My noradrenaline, serotonin, and dopamine need to go through this pathway. And it learns. So as if you're making something really, really joyful. So you have more postsynaptic receptors, more receptive to the monoamines, and the expression of the genes that has been related to depression, particularly BDNF, is stronger. Okay, so and after all, you will find when you look at fMRIs, so all the lightings, the scans that light up when you give people tasks, that connections between the mesolimbic system are getting better. The areas that are related to serotonin production and dopamine production in particular. Okay. So that's it. Go ahead. You're on mute. You're on mute.
Sorry, the question is for how long and how many sessions, which I know that you will talk about.
I will talk about it. So the number of I'll come to the depression when I talk about the depression in particular. I think just for the sake of time, I'm going to wrap up the mechanism of action. I'd like to talk about the mechanism of action. I know that in the previous presentation I spoke a lot about this. So quickly to say that RTMS increases the level of monoamine oxidases. It reduces the corticotropic release hormone, so less stress in the body, regulate the rhythm of the thalamocortical activity, better emotional regulation. It deals with the hypoactivity in the dorsolateral prefrontal cortex, the anterior cingulate cortex. All are areas. So if you look at these areas, all are areas in near the frontal lobe here are hypoactive in blue, if you can see. And by stimulating the nerve cells, we have seen that in studies, the glucose levels and oxygen levels are increasing in these areas. Okay, so we're having better perfused and better connected electrically, and after a period of stimulation, those areas between the frontal lobe and below the frontal lobe in the anterior cingulate, all the way down to this area when you have all the production of dopamine, internal capsule, and everything else and the limbic area are better connected. So you have better production of serotonin, dopamine, noradrenaline, and better connection between your areas of frontal lobe, insula, deep inside here, but also the cortical, the limbic system, and the basal ganglia and hypothalamus, meaning that you have better emotional regulation, meaning that you have improvement in the cognitive functions, and meaning that the mood improves. Okay? In summary, if we give low frequency, that gives inhibition, long-term depression. If we give high frequency stimulation, that gives long-term potentiation, improving synaptic plasticity, modification of glutamate and GABA receptor functions. What are the indications of TMS? TMS is really good for depression. It works in bipolar depression, although some places will have license and other places wouldn't have license for bipolar depression, because it can cause switch to mania, not more than any antidepressant given in bipolar depression. OCD, migraine, smoking cessation, but there are emerging areas in PTSD, schizophrenia, chronic pain, substance use disorder, and I'll talk about a few of them. So I'll just be more specific, talk about rTMS in depression. We normally stimulate the dorsolateral prefrontal cortex, so the left side in most cases. Some people stimulate the right side. It's okay as well. The frequency of stimulation is 10 hertz to 50 hertz. So that's how many pulses of single pulses of stimulation happen in a minute. The duration is session every day, 5 days a week or more, for 30 sessions. That's what we give. That is changing all the time. So some people now give 50 sessions of stimulation. Okay? The whole idea is you're bringing the patient every day to have stimulation. It's like doing physio. If you stop it for long enough, the brain will forget all the changes that you have been trying to do. The neurons and the synapses will forget all the pushing of activities that you were trying to do. So every day they come for one session or more of TMS. The session will have anything between 600 to 3,000 stimulation. And the total number of stimulation per day is anything between 600 to the maximum protocol, which is 18,000. There is another protocol which has come with bigger number, but that's really out of range So you can give 18,000 stimulation per day, up to 18,000 stimulation per day.
And sorry, when you say 18,000 stimulations per day, how long is that? Or how long is 3,000 stimulation?
3,000 stimulation is done over 17 minutes. So 18,000 is actually 9 minutes, 10 times per day. That's actually 90 minutes, but
So about an hour and a half
not
for the maximum number of stimulations.
but not continuously. So we leave the patient at least 30 minutes, but most people say up to 50 minutes between every session. So 10 sessions a day.
Oh, okay. Okay.
Okay, that's called the SAINT protocol.
The
SAINT protocol.
Saint. Okay.
SAINT as in
Qadis.
Qadis. It's an abbreviation for for the place in Peterborough in America.
Oh.
So something, whatever is the name of the center, they managed to abbreviate it to a SAINT protocol, which is actually a very, very effective protocol, has really good efficacy. So the TMS machine, I'll show you a better picture, has a coil. The coil will be placed on the patient's head. It is connected with a TMS stimulator, a source of electricity, and a monitor to observe the treatment, how many stimulations are happening. This is our TMS unit. So we have the TMS stimulation unit, a capacitator connected to the treatment coil. And this is, we have two coils, one for assessment and one for treatment. That doesn't have to be the case in every unit. Some units have just one coil for treatment and assessment. We have something called the neuronavigation system. That's probably just to help us position the coil in the right place. Okay. In the initial assessment, my job is to try to find out two things. One is the amount of electricity, the amount of energy that the brain requires to be stimulated. And how would I do that? I stimulate something I can see. If I stimulate the motor area, I can see a twitch in the hand. Okay, and it is the same brain, it is the same gray and white matter. So whatever stimulates the motor area is going to be stimulating the dorsolateral prefrontal cortex. So we do initial measurements to find approximately where is the M1 area, motor area, and we start to to stimulate around the area where we expect the motor area. Okay, in our unit we use this neurostimulation, the neuronavigation, which when it takes the measurements from the patient's head, it can give us a guess where to find this area. But we still need to move the coil around and stimulate around this area, clicking, 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 until we see a trigger, until we see a twitch in the patient's contralateral hand. Okay? So stimulate, stimulate, stimulate in this area until you see a twitch. The patient will be putting their hand in front of them in a relaxed position. Once we see a twitch, we start reducing the dose to the minimum dose that causes stimulation of the hand, a muscle twitch in the hand. And that would be the dose that stimulates the brain of this patient. Okay? Then we use a little bit of anatomy to understand. So this is the area we stimulated to cause it. Oh, sorry, I have two screens and I changed on a different screen. Now, this is the area we have stimulated to get a twitch in the hand. we use either a cap and do measurements because and draw a line on the cap for 5 centimeters parallel to the midline, and that would be the dorsolateral prefrontal cortex. In our case, we have the neuronavigation, which electronically on the machine will capture this position, and we will be able to identify the location of the dorsolateral prefrontal cortex in a much easier way. But most people use the cap and draw a line from the point where they manage to get a stimulation of the right hand. And from this point, you find the position of the dorsolateral prefrontal cortex, which is a common treatment point for depression. After that, the nurse will be seeing the patient every day to place the coil on their head. And after that, after she places the coil, then the treatment session will start. This is how it sounds. That's a lot of stimulation, by the way. So if you, that's possibly like 70 stimulation in this.
I'm not sure I can hear the video. Is there a video?
There is a video, and it's just a clicking noise. Okay, it's not the best quality, I have to admit. We need
It's kind of similar to the
louder-
MRI MS. This is my knowledge about it.
Yeah. It's a clicking noise, very similar to what people hear in the MRI machines, but not as loud. How effective is TMS? There has been multiple meta-analysis confirming effectiveness of TMS for depression. The response rate on average is anywhere between 60 to 70%, and the remission rate is around 30%. That is in a population where the patient would have had at least 2 antidepressants in the current episode. So if you go back to study the biggest trial in the treatment of depression, third line usually the usual response rate is 13 or 14%. So if you have a response rate of 60% as a third line, that's really better. Sustained response is around 50% 1 year in one study. We did our own study and we found something similar, slightly better in the Bright Mind study. But what's really good about TMS in depression is people who responded initially tend to respond again. So high rate up to 84% of response in repeat or rescue TMS. Side effects, the serious ones are the risk of seizure. It's around 1 in 30,000 treatments. There is a risk of hypomania, very small, and it's more significant in patients with bipolar depression. There is a risk of vertigo. There are more common, less serious complications like headaches, scalp discomfort, facial twitches, eye watering, tinnitus. What are the contraindications of TMS? Fairly well tolerated, but if the patient has anything metallic, ferromagnetic in the upper part of the body, they can't have a magnet near their head. Implants, any implants near the stimulation site are not going to be allowed. We have to be very cautious with the risk of the history of seizure. I do not treat anyone with active epilepsy. Okay. Emerging indications for neuromodulation.
If you allow
Go
me,
ahead.
before the emerging indications, so let's say you have a patient, and I'm wondering about mine now. And I know I've done the screening questionnaire that you have, but when you talk about implants and things like this, so does that mean basically people who have porcelain teeth or have nails in there. And
No.
is that the type of implants that you're thinking about, or what sort of implants would?
No, we're talking about a ferromagnetic usually. So dental implants, all of them, if done in recent years, will be platinum. So it's not for ferromagnetic. It's not going to cause a problem. I have a specific issue with people who worked in metal work. For example, I had two people who worked in whatever, what do you call it? They had to work in metal and all joinery and stuff like that. And I think both of them had cardinals, small metal stuff in their eyes. They couldn't, one of them could not tolerate. He felt significant pain in the eye as soon as we put the stimulator on. So anyone who has a history of metal, the first one I sent them, both of them I sent to ophthalmologists to check before we started treatment, and they couldn't find anything with a slit lamp. But I had to send one of them to have orbital MRI, orbital CT scan. Because it wasn't clear why they're having this pain. And they continued to have the pain after the CT scan, and we had to terminate. So there must have been a sharpness somewhere. It caused the pain in one eye consistently.
Okay. But things like teeth implants, because this is what you think about generally, teeth implants, or, I'm assuming there aren't many metal shoulder replacements, a knee replacement or a hip replacement, something.
No,
These
or
are all
anything
these are all mostly
below
platinum.
your shoulder. Anything below the shoulder is really far from the magnet, really far. So the magnet works for around 30 centimeters around it. So anything beyond 30 centimeters is not going to.
Obviously, piercings and things like these, you'd remove that.
They need to remove everything before the treatment. What one problem we have, it's not as common in Egypt, is the colored tattoos.
Okay.
Because they are full of iron. The red tattoos in particular.
Oh, okay.
So they can heat. They can overheat them.
Puts me off some of my fantasies then.
Okay, here we go.
Sorry to interrupt. I apologize.
Either red tattoos or TMS.
Okay. That's so the potential to TMS or the red tattoos. I might go for the red tattoos.
Okay.
But sorry to interrupt you. Yes, thank you.
No. It's good. I know we're running out of time, Hussein.
Officially, we have about 4 minutes, but I think we can. I think we can continue to carry on with the because I am very interested in the emerging indications. And we'll see if someone has any questions, or there aren't many questions, to be honest, so far. But I'm encouraging people, if there is any questions, they can raise their hands or they can just put it in the chat. But I think everyone else is a bit more polite than me and waiting for the end.
Okay, so neuromodulation for eating disorder, a lot of trials. TMS, transcranial direct current stimulation, and even deep brain stimulation all have been applied with various degrees of success. If you think about it, especially in bulimia nervosa, you think about the reward system. We're targeting the reward, the frontal lobe, the dorsolateral prefrontal cortex, and we're regulating this reward system. And I've seen a few of my patients who have a secondary diagnosis of an eating disorder where they felt, actually, I don't have the same urges to binge when I'm having the treatment for TMS. Okay, but again, that's still early to say that this can be a treatment. I think that the research in this area is very promising, that TMS will have a role, part of it, in treating bulimia and maybe anorexia nervosa, alongside medication and psychotherapy. So it will be part of a package. Really interesting the developments in memory and cognition. RTMS probably has large effect size and larger than certain anti-dementia medication in certain small studies. So we'll wait for the bigger studies to show the effect size on it, but it is a good tool to enhance cognition and enhance memory. And one would think that actually even without cognitive decline, people can look at this, whether it's ethical or not, as a way of enhancing performance and cognition. And I know in certain countries, they have looked at TMS as a tool of cognitive and performance enhancement for athletes. Right or wrong? That's another debate. Okay, so the target in TMS for cognitive decline is a dorsolateral prefrontal cortex, obviously, because it is concerned with a lot of the executive functions, and the hippocampal area because of the memory. Next, really interesting in autism spectrum disorder. Again, dorsolateral prefrontal cortex, but medial prefrontal cortex as well as target areas. And there has been a few studies that have shown improvement in social functioning. I have a patient I've been treating for the last 6 years with significant depression, but also significant problem with social communication for years. The guy has known me for the last 6 years. He never attended his clinic appointment on his own. And he almost always had very short, brief answers, very limited eye contact, as you would expect in autism spectrum disorder. And most recently, I decided to treat him with TMS. And the results are amazing. This guy is coming on his own to see me at TMS clinic, and we're having chats together. And half of the time he's looking at me. I think it was probably the first time he's recognizing my face. Really transformative for this person. I had another person with severe autism and personality disorder whom I treated when she was admitted to the ward. And just during the time of her admission, it was amazing. The consultant on the ward came to me and said, "What have you done? You cured this patient." It was very short-lived, because as soon as we stopped the treatment, she reverted back to and that was something we didn't plan really well, because she struggles with change. So the change of routine, but we're rectifying this. This person has spent most of her life just not talking to anyone and self-harming. When we treated her depression, it lifted up the depression, and the self-harming behavior reduced during the time of treatment, and her social communication skills slightly improved, which is not bad. For someone who the plan was to put in rehabilitation for the foreseeable future. So this combination of depression and autism, I'm keeping an eye on this and collecting data on people who are having both conditions, and trying to see the changes that happen not just to their depression, but also to the social communication skills. Talking about self-harming behavior, there's some good evidence that especially the intermittent theta burst, which is another form of TMS, works really well in reducing self-harming behavior. I'll give you another example. I had a patient very known to me who was talking about committing suicide, sent 2 social workers, I think got her from a bridge, and said, oh, definitely needs to have an admission today. Now we can't really maintain her safety. And I said, okay, I know this patient really well. I'm going to bring her to the TMS suite. And we gave her multiple sessions a day. So we gave her the first day, I think 3 or 4 sessions in quick succession. And by the end of this, all the urges to kill herself have gone. The TMS in reducing the suicidal urges is likely to be very effective for the use in acute psychiatric facilities. And with the theme of the month, and every month, ADHD, there is good evidence that we should investigate TMS more in ADHD. And once more, I had a patient who came to me from another service, and they said this guy's been depressed for the last 8-10 years and never responded to any treatment. They gave him every sort of treatment. When I sat with the guy after the first assessment, I was convinced that 90% of his problems are actually related to ADHD. But I decided, nonetheless, there has been some depressive symptoms, so we gave him a full course of ADHD. And I think he's been discharged for the last 4 years from services because we initiated this that gave him a lot of calmness in his head, and his depressive symptoms completely resolved, and later assessed for ADHD and got treated and completely back to normal, not requiring any intervention from any services. Okay, neuromodulation for pain, inhibitory, going back to the inhibitory modulation. You can apply inhibitory modulation to the brain, to the head, and that can cause reduction in certain types of pain, particularly neuropathic pain and fibromyalgia. Fibromyalgia is a very, very difficult to treat condition. So if you have no response at all from everything else and have 30-40% improvement from fibromyalgia, I think that's significantly better from what's available for most patients.
Michael, I don't want to interrupt you.
I'll just take it to this point. I think that's probably more than enough for us. I'm not to. After that, I'll be talking about other types of neuromodulation, but they're not as important as TMS. So I'm going to stop here just to allow us time to have a chat, ask questions, have discussion.
Yes, thank you very much. I was going to say the same. There is a question on the chat that says, do different conditions have different dosages / stimulation number? I guess we're going to have about 5 or 10 minutes for questions.
I'm going to stop sharing so we can, if you guys want to kind of
shout out your question or just write them down.
Yeah.
But yes, the question that we have so far is, do different conditions have different dosages?
There are different
or I'm assuming protocols.
Yeah, there are different protocols, and yes, so there are certain protocols which do not go as high as 100 or 120% of the motor threshold, but for every condition, there are also different protocols which are high and low. So, for example, for anxiety, you go for 100% of the motor threshold. So the motor threshold is the same amount that you have used to create a muscle twitch. That's 100% of the energy you need to create a stimulation of a brain cell. So that's the normal, that's 100%. For anxiety, inhibitory protocol, you go 100%. For depression, you go for 120% overstimulate for some other inhibitory protocols, you can go for down 80%, but we don't use them in every day. Okay, so I normally use 100 and 120%. I don't go that often to less than 100%, except if I'm worried about the risk of seizures.
Okay.
Okay.
And if let's say if you're going to treat, and I'm assuming this is behind if you're going to treat pain or OCD or let's say things that the anorexia nervosa, would you use a different protocol, stimulation wise or area wise, or?
Yes, absolutely.
It's,
So
it's everything
OCD,
depends. It has a different way. It's not all going the same place.
OCD, you go for the orbitofrontal here, which is more effective. For anxiety, you go for the right dorsolateral prefrontal cortex, and you go for a slow protocol inhibitory.
Okay, I'm going to move on with the next because we're getting more and more questions. I don't know if you can read the chat, but I will read it out for you. What advantage does RTMS have over ECT in regards to mechanism of action, and is there any benefit of trying RTMS if ECT did not work? So
Okay, so
how do you
RTMS,
how do you compare to RTMS with ECT?
so indications are slightly different. So RTMS is for the moderate to severe depression. ECT is usually reserved to the severe and psychotic depression. RTMS does not have any cognitive impairment problem. ECT will cause, in certain individuals, autobiographic memory issues. Okay. RTMS is not going to work well with psychotic depression. ECT will work really well with psychotic depression. So there are two different groups of people, but yes, there has been a few studies to show, very small studies to show actually people responding well to RTMS when TMS has not responded. Actually, I had a patient last week who
You mean when
finished
ECT was not helpful?
when ECT didn't work, RTMS. I have a patient who responded okay to ECT, but was actually struggling with memory issues. He came to us in clinic and he had a full remission on TMS after ECT.
Thank you. That is very helpful. I think that's a bit of an interesting thing. I don't know. I worked in Egypt for a bit, and I know you haven't been working there. And ECT is quite offered quite early on in treatment. I found it quite unusual when I came here, and they say, "Oh no, you have to have two consultants to sign for ECT. You have to do this. You have to do that." Da, da, da. It used to be you have depression, there is tablets, there is ECT. I don't know if things are still the same, but I know that ECT is far more commonly used. We definitely used it for bipolar. We used it for treatment-resistant schizophrenia. Someone didn't want to take tablets. They might have had patients who said, "Oh, I like the ECT. I'm going to come and have a session once a week. It's better than the side effects of the tablets." And that was essentially enough for them. And I know Americans are a bit more liberal when it comes to ECT than us.
I don't mind ECT at all. I actually like ECT. I think it's a very good tool, but not for everyone. So for moderate depression who's not tried a couple of antidepressant and maybe TMS, why to put them at risk?
I agree. I agree. Coming in and into that, because with the anesthesia and with the risk and these things were not always fully considered. I think we'll have to stop with the questions. We have few. I am going to say out the ones that we already have. One of them is, what age can we start TMS in children?
We don't have a license for children in the UK yet. The US, I think, talking about 14. I think, 14 will probably be the age that will be coming next. There isn't anything to say that it's going to cause major problems when used in children, but that's still in the research arena, not in. So I think there are some groups trying to research it in the management of social difficulties in autism in children. But again, that's research. That's not clinical practice yet. And the research, we are starting ourselves in January. Our group will start giving TMS for children age 18 and 14 and over as part of research, because we don't have license in the UK for children.
Leah has a question saying, can we reverse engineer TMS in a sense? Basically, can we use TMS to induce a mental illness? I'm not sure if you have much information about that, like a personality disorder or a mental illness.
No,
by inhibiting the areas you have to stimulate.
It's modulation. It's the Goldilocks kind of الأواني المستطرقة. عارفين النظرية بتاعت الأواني المستطرقة إنك أنت you can actually reduce one, but it all goes to equilibrium. It's not necessarily going to go down. And the high will go to equilibrium, not go down. So modulation is about bringing everything to equilibrium, not obviously, if you are going to try very hard and use unethical protocols to stop someone from having all sorts of activity, yes. But in the current protocols, they work in reducing what's high. It's like lithium effect. When you're high, brings you down, but down to normality. When you're down, brings you up to normality, but not necessarily going very high manic or very low depressed. There is a small risk of in bipolar depression of bringing illness because of switch phenomenon, because people can become manic. But that's a very small risk, actually.
And it's a well-known risk also with treatment of depression in general. Yeah.
Anyone treated for depression, they can go high.
Yeah. Last question. What are the recovery rates for TMS? And what is the difference between TMS and EST? Do you mean ECT or EST? I'm not sure what is EST. I think we did talk about TMS and EST, but we're talking about recovery rates. So if let's say for patients with ECT, from my knowledge, you'd have 6 to 12 sessions. What does the data say, or from your experience, about
up to
how
70% for ECT?
How long do we need until we have another course of TMS?
Okay, so what I have firstly is I started this 5 years ago, almost 5 years ago, and I had patients who started, never had the treatment, recovered, never came back. And then I have patients who actually come back every year or two to have an extra course of treatment. And I have a few people whom, if I don't give them the maintenance, they will fall off the cliff. The improvement rate, people who find it really helpful. When I say improvement, we use the Hamilton Depression Rating Scale, and improvement is anyone who's not in remission but managed to have a 50% reduction in the score, the depression score. So if they start very severe, 24, now there are 12 mild to moderate depression, that we consider this as improvement. But if it started at 24 and went down to 20, that's not improvement for us. So we use a very kind of scientific way. That's the standard used in research anyway. And we have 60%, 62, depending on the time, 60% of people who come to us improve significantly. You have in ECT around up to 70% improve significantly. So it's not far from ECT, but it's a different protocol. And a different group of people. All right?
Yeah. Thank you very much. I am very, very grateful for this session. That was very, very helpful and very, very enlightening. I really appreciate it. I would like also to, I know that you are planning a course on TMS soon in the UK.
Yes, there will be a course. There'll be a course in March in Manchester, in the UK. If someone who is planning to start a practice, get a TMS machine and do this, whether yourselves or colleagues, حد مهتم, ابعتوا لنا email get in touch, and through ThinkHouse.
Yeah.
So
We're happy
it's
to do that.
okay.
And if you get us the
And we'll
information, the
send you the
details,
details.
we're happy to send it to everyone who's subscribing to the. I am not sure if everyone here has come through the subscription. مش عارف الناس كلها جاية من subscription or from different social media. I did put the link just to subscribe on the free resources webinar. You just put your name and your email. It allows us to send you the link, the recording for this. So you can view it again, you watch it, you can even share it with your colleagues as a part of the free webinars. We also send for everyone who's attending today. So we have 2 courses coming up. We have the insomnia, complex case insomnia next week, essentially next Saturday, and the week after is Dr. Kurkar's own adult ADHD. I know you're an expert in adult ADHD. You have been practicing it in both public and private. And you're gonna and I know I have a very special interest in that, and I ask you all the tough questions to put in your course about how you differentiate ADHD from complex trauma and personalities and literally everything else. So I'm looking forward for that. So the course is on the 15th. If you sign up to the subscription, we'll be sending discount codes for everyone who attended today's session that you can use yourself or even share with colleagues if you wish. In the upcoming period. We are happy. I hope we've answered everything. Everyone, thank you very much for attending today. Thank you again.
Thank you, Hussein. Thank you,
Very,
Shukran,
very
Shabab.
kind. We really appreciate it.
Hopefully see you again
see you all,
in the
inshallah.
next webinars.
Inshallah, looking forward for more. I have a few more planned for you. نشوف بس depending on your time. I know you're a very busy man.
Sure,
Thank you very
sure.
much, everyone. Really appreciate
Okay.
it. Thank you.
Shukran, shukran. Bye. Bye.